Okay, so in the next minutes, I'm going to talk about preparative planning in the upper limb when using virtual low-cost tools. I think this is an interesting topic that we have developed here in Replicative Hospital, where I've done my residency and where I currently work, although right now I'm in Spain during my fellowship. So what are the objectives of this talk? We will recall the importance of surgical planning and templating, know about what current virtual methods for planning there are, to explain how we can create cost-free or low-cost tools for this templating, and represent all of these with applicable clinical cases. So as a brief introduction of planning, we know that there are softwares that will allow you to plan your surgery either for fractures, for replacement surgeries, and there are many papers validating these different types of planning systems. They are very useful, and I had the luck to use some of them when I was in external rotations. There are softwares available that are friendly, easy to use, and that will give great information for your surgical planning, especially on complex cases. But the problem of these are the costs. And we, being in Peru, our institutions, even though they are referral hospitals, they are not able to buy these softwares. So what can we do? We look for the guidelines of the AO when we have this traditional surgical planning, when we had to cut the x-rays or templates and do it by hand, trying to reproduce what we wanted to do in the surgery and translate that to paper when using these transparent films. That was very useful, especially when we had physical x-rays. But at the moment, the x-rays are not printed, they are in a DICOM system that we can only see in the computer. So these things that we did in the past, or even in the first years of my residency, were no longer an available option. So we wanted to move on, and we started creating these implants made in the computer and designed to have the similar applications to translate exactly what was on paper to the computer with the available tools that we have. We of course know that the operative planning includes many aspects, not only the implants, but also the maneuvers, the risks, the goal of treatment. We have more than one fracture or one problem to assess. We need to know where to start first. But this lecture will specifically enter on the implants because this is what we have decided, and I think it's been very useful. In the beginning, we started doing this with fractures. This is a distal radius fracture. The CT scans are always very important, especially in articular fractures, to help us on the planning, to know what implant to use, what approach to use. And based on this, we design our own templates. These are designed initially we used Paint as a very low-cost tools. Then we try to do it a bit more professionally with a CorelDRAW, which is also a low-cost program to be used in the computer. What can we do? What is the idea of this? We wanted to replicate exactly what we did on paper. So we remove all the bone fragments of the fracture, we reduce them, we give them the angles, the natural anatomic characteristics that we want to achieve. We translate these to the PowerPoint, so we can then add our implant already to the scale that we had of the X-ray. We can also do this in the lateral picture and add it to our presentation to have a simple preparative planning. Why is it low cost? Because we are just using Paint to cut the pieces. We're using PowerPoint to rotate, to translate, or to add the template on our picture. This is a small video. In our hospital, we do a lot of hip fracture. I think that's one of the things in big hospitals. But this is the idea. We cut this picture in Paint, and then we just reduce that just as if we were working on paper, but with these available tools. Then we designed the templates that we wanted to use, and we started to applicate these to more complex cases. So that's the thing of this presentation. So this is a shaft fracture of both ulna and radius. And what we can do here is reduce the fracture, demonstrate these, apply a plate according to the approach that we might be considering. This template is already scaled to the dimensions. You see this small white ball that is our frame to do the application and the sizing of the implants. And also we wanted to do a bit more, because every time we face something new, we look for more problems that we need to solve. So this is a Phyllis plate. Not only in our designs we use the implant, but also the directions of the screws, the height of the tip of the plate where we want to place that in. And in this proximal humeral fracture, what we can do is just using these similar tools to place our implant in the exact position that we want to achieve in the surgery, and especially in this E screw that we want to go as close to the calcar as possible, and see if the plate will be useful for us. Something that we've been seeing is some of the implants are not designed to Peruvian population, but I think that will require more studies. But this is a very good idea to approach and to do everything before our surgery. Then we can add the number of positioning of the screws and do this. Also, we wanted to improve the imaging of these implants. This is a black background, but if we translate it to a white background, we can also see we accomplished this by drawing a white and a black line with every implant. Very useful. And now I want to show you some complex cases where we can apply these. For instance, when we want to work for osteotomies for malunions, we know that there are deformities that it can be either angular, rotational, or translational. Even though they are three-dimensional, we don't have the tools that are available in maybe other places to plan the surgery. For instance, this is a 3D customized planning where they reproduce with the CT scan the reconstruction of the contralateral side. They invert the image, they merge those two images, they plan the cuts with this very sophisticated software. They can even design a specific customized implants for these complex cases. But it looks very beautiful and very useful, but these are not things that we have available in our country, and probably it will take so much time for us to achieve that. In our reality, what we do have is the concepts, the rules, and the types. For instance, this is a 2D image, and we can apply this to any other osteotomy that we want to plan. We figure the center lines, and we enter the cora, which is the center of rotation of angulation. This will give us a bisectrix, and this other point will be the ACA, which is the axis of correction of angulation. If we go work on this axis more laterally and trying to do an opening wedge osteotomy, we can align the defect. And if we do it more medially in this case, we can do a closing wedge and reaching the similar outcomes. And we can do this only by using PowerPoint and Paint. So I think that's the wonder of this device. In other complex deformities where the cora is not matching the ACA and the tip of the deformity is further distally, we can say if we perform an osteotomy close to the ACA, our results will not be as expected. But if we do that closer to the tip of the deformity, we can correct that bone deformity. And I think this is very useful because we can try as many times we need this in our paper. Sometimes it can be hard, but the more that we do it, I think it's easier. We can get used to that, and our residents are pretty happy with this. This is a 16-year-old male patient with a malunion of the radius shaft. So we draw our lines, we measure the angle, if it's 20 degrees of anticurvatum, then we can measure how much wedge we want to remove for a closure wedge, and how many, in this case, 5 millimeters of anterior cortex would be enough to do a 20-degree closing wedge, and then we place our design implant, and our surgical planning is noted to that. These are the intraoperative images where we do exactly what we planned. We measure this in the OR, we do the closing wedge osteotomy, and our results are pretty similar of what we have planned. This is another case, a 15-year-old female patient. She had a previous history of elbow traumatism, and then she comes with this deformity. This is the plain X-rays, and when we measure this, we know that there is a deformity, acquital valgus, and we planned also doing a closing wedge osteotomy. These tools provide us the availability to measure the width and the height and where to do this osteotomy and to place the implant that we need to work on. We discussed this with the head treating physician or the or the attending, and we obtain also these pictures from the OR, reaching also what we have planned. We know that sometimes sinusotomy trying to be perfect is not always the goal, but to be functional. The patient at the year follow-up achieved these expectations. This is another 15-year-old patient, also with a cubital valgus in this case, but here we find some abnormal malunion in the lateral column. The CT scan reproduction shows us this. The ectoscopic deformity is close to 35 degrees of valgus, but if we look for the X-ray, the valgus is a bit more, close to 43 degrees, and we want to correct that. We start planning maybe to correct first the malunion of the lateral column, and then to perform an osteotomy for the medial aspect to final the correction of the last 10 degrees. Here we have a functional physiological valgus of 10 degrees and the application of our implants. These are the intraoperative pictures trying to achieve what we have planned. Here we notice that we were not able to solve the lateral problem of the column, but the functional outcome was good enough, at least in our expectations. This last case is a 48-year-old male, high energy trauma, murdered by accident. These are the X-rays, segmentary ulnar fracture, and a complex distal radius. If we see the CT scan, the distal radius is completely destroyed, possibly not amendable for primary reduction. So what do we plan? Initially, we try to fix on the segmentary ulnar fracture, but we have considering that sometimes we not always have the proper implant. We need to see the length of the plate that we want to apply, and if we have that plate available in our institution. Otherwise, we might try to do a double plating. And here, since we are not able to reconstruct the distal radius, we want to fix the large bony fragments like the styloid or the volar teardrop, and use a spanning plate as always, or in our institution we don't have a spanning plate, so we use as a LCP plate, and we need to see if the longest LCP plate available in our institution will be useful for this. Otherwise, we need to change that to external fixation. So we plan this, and hopefully we can translate this to the reality. As we have seen, the plate was not long enough to solve the ulnar fracture, but it was long enough for the spanning plate, and the ulna had to be a double plate. So I think the take-home messages of this is to fail in planning is to plan in failing. I think this is an important thing. We need to address all our tools, what we have in our institutions and in our hands to improve our planning. We need to remember that in paper or in the computer, we can try as many options and make as many mistakes or redos, but not in the OR. So we need to work on this and have all the surgical team to be aware of our plan, what we have, and also adapt our plans to our realities. Thank you very much.